Good afternoon, and thank you for joining us for today's webinar, Interpreting Cone Beam CT Image Exams, Opportunities and Challenges. I will now turn the presentation over to our moderator, Dr. Patrick Browning, RadSite's Chief Medical Officer.
Thank you, Julie, for that introduction. Thank you, everybody, for attending today's webinar. I think it's going to be very interesting and a lot of fun. We have some really qualified people on the panel. First, I'll introduce myself. I'm Patrick Browning. I'm the Chief Medical Officer for RadSite. I'm also a practicing radiologist and involved in several different projects that involve radiology. Been with RadSite for about 4 years now and enjoyed working with everybody on the various committees trying to improve medical care. So with that said, I'll ask Gary Carneal, who is filling in for Judith Turner today, who is stuck on an airplane. I'll ask Gary to introduce himself.
I'll do my best to replace Judith, but she's got a unique perspective and a very funny person, so I don't think I'll have as many funny jokes as she does. But I've had the honor to be RadSite's president and CEO for just over a decade, and my really area of specialty is accreditation. I've helped bring to market over 25 different patient programs for 4 different organizations over the past quarter century.
Excellent. And Mr. Gill, how about you, if you introduce yourself? I'll be formal for the first couple of minutes.
Sure. My name is Barney Gill. I'm up in the Northwest in the Seattle area. I work with BeamReaders in a role of customer development. And so I'm responsible for helping dental practices who want to submit scans to get an oral radiologist to review them and get help. And I'm also responsible for any goals or help that our radiologists need if they want to do other professional development, lead courses, things like that. I work to try to make their life easy. I've just been with BeamReaders for about 4 years, but I met the family, the Hatcher family that founded this group back in 2014. As the current CEO, Corey Hatcher, and I were in grad school together. BeamReaders sort of started and exists because the founder, David Hatcher, who's an oral radiologist, he was the first private practice around 2001 to get a CBCT to scan dental patients. As CBCTs started to become a bit more prevalent in the US, people just started sending him CDs left and right, and they started to stack up around the dinner table and everywhere around his house, and he needed a team and help and a platform. And so BeamReaders sort of got started to help all those dental professionals taking cone beams, and so that's what we do here today. It's been a good group to work with so far, and thanks for inviting me to this.
Absolutely, my pleasure. And Dr. Brown?
Yeah, it's a pleasure to be here today. Jacob Brown, and I'm also a practicing radiologist, so I sympathize, Patrick. Yeah, my subspecialty is neuroradiology with head and neck and craniofacial emphasis, and I'm also the Chief Medical Officer of DentalRay. And we're a platform that connects physician radiologists who specialize in head and neck imaging with predominantly dental professionals that are performing cone beam CT at the point of care.
Excellent. Well, thank you all for participating today. I think it's going to be an interesting conversation. I really can't wait to hear what my esteemed colleagues have to say. So first up is going to be sort of a history and state of the cone beam CT accreditation program. So Gary, you're an expert in that, so I would ask you to maybe start that ball rolling.
Okay, right. Well, just for a couple quick comments. RadSite was established in 2005. It was in 2010 or 2011 that we began working on the Advanced Diagnostic Imaging Accreditation Program pursuant to the Medicare Improvement Patient Protection Act, or MIPA, and we got recognized. We were the 4th accreditation body to be recognized by CMS in the fall of 2013. So we'll be closing in our 10th year anniversary of actually having the Advanced Diagnostic Imaging Accreditation Program for CT, MRI, and nuke med. One of my joys in my career in terms of developing accreditation standards is really to supplement state regulations, generally accepted standards of care, payer guidelines. Accreditation, when done right, can really provide the standards and a third-party assessment process that really kind of moves the ball forward. At the end of the day, it's about the patient, right? So it's accreditation can be an aggregator to work with the different stakeholders to identify new evidence-based pathways, process structure, and outcome measures. Interesting enough, for cone beam CT, we had been accrediting CT, and we started hearing about these units called cone beam CT, and particularly in the dental field, as Dr. Brown and Barney will attest, they've been around for some time. There's an estimated 30,000 plus dental cone beam CT imaging systems that have been installed, and now exponential growth on the medical side as well. But there really wasn't too much in the way of regulations or standalone accreditation programs. So in 2017, we began basically what ended up being about a 3.5-year journey. We started off by hiring some national experts that were cone beam CT physicists to begin to understand some of the differences between the cone beam CT acquisition technology. And we have several other webinars that we've hosted this fall. You can learn a little more about that if you're interested. But long story short, we ended up developing a set of standards that kind of track the MIPA requirements, dealing with professional requirements and the technical component, including image evaluation and physics testing. And after 3.5 years, we were able to actually get it approved by CMS. And so we have 2 accreditation programs for dental and 1 for medical with different specialties. And we were able to really kind of match it up with the traditional ADI standard. So we actually got recognized by CMS and by now many private payers. One major point of opportunity is how cone beam CT images are interpreted, which of course is today's subject matter in terms of what we'll be talking about. But if you're interested in learning more about the cone beam CT accreditation program, you can download it on a complimentary basis from RadSite's website. So Dr. Barney, I'll turn it back over to you.
That's a great summary, Gary. And I have to say that I've always been surprised at how many units are actually out there in the wild practicing. And I think that leads to a whole lot of questions regarding interpretation, accreditation, overreads, image quality, the age of equipment, a lot of things like that that are very impactful that we'll move into. So first, why don't we talk about interpretation? So I think definitely Jacob and Barney can both speak to this, but there are a lot of questions. Who does the initial interpretation? Should there be overreads? I mean, if there should be, why? What's the purpose? Are there other things to look at than just that one area of interest? How do you make sure qualified providers are doing the interpretation? And should radiologists intervene? So a lot of questions around that. So I would ask Dr. Brown actually to maybe approach it at the beginning, then we can all just pile on.
Yeah, absolutely. Well, I'll tell you a little bit about kind of the inception of our organization. So, I have to say that because it speaks to this a little bit, I have to say that I'm a little embarrassed that I'm late to this. You guys have all been doing this for longer than I have, and I have to say that with cone beam CT specifically, I've been doing radiology for a long time, but usually I'm sitting in a radiology department. And, there's kind of millions of dollars of those big, donut-shaped traditional helical scanners that we're familiar with. And I was kind of sitting back there kind of smug thinking, hey, we're getting the best imaging out there and everybody has to come to us to get the best imaging. The patients have to come to me, basically. And I have lots of dentists and dental professionals in my family. And so my brother and my cousin, they come to me and they say, hey, this is becoming kind of standard of care in the dental industry. We're replacing our pano machines with these CT scanners. And can you guys help us? We are familiar with the dentition. We know my brother's an orthodontist and he has these, he's smarter than me. You might know that already because he's an orthodontist, but he has like a 2-hour lunch every day. So he's smarter. But he knows all about these, this angle classification of malocclusion, and he knows everything that he needs to know to interpret that study. But in the process of obtaining, the images that he needs for orthodontic treatment, he's getting a large field of view that includes, the majority of the head and neck. And he comes to me and he says, hey, these are areas that I'm not comfortable looking at. Can you guys help me and kind of do a safety overread for these patients? And I looked at that scan and I thought, and I was blown away. I was humbled, I would say, because I really couldn't believe the quality of the imaging that's happening at the point of care, where the patient is without requiring them to go get another appointment to go to another imaging center. And so I kind of had two thoughts at the same time. One was, this is amazing, and I'm embarrassed that I didn't realize this was happening. And two was, absolutely, somebody needs to be reviewing all of these scans. And so our organization, takes the approach that we take in the rest of the imaging world or the medical imaging world, which is that an interpretation could best be provided by somebody who's obtained who's completed a residency in diagnostic radiology, which is 5 years, and then is also approved by the American Board of Radiology. And then we also take the step of making sure that each one of our radiologists has a full state license to interpret the scan in the state where it's being performed. So we basically, because it's really the only thing that I understand, is we apply the same standard that we would apply in hospital-based or the rest of the medical world for interpreting CT. So those are some of my initial thoughts, but really I'm just blown away at the imaging quality, and compared to us in the medical world, and I would say like the average general practitioner in the medical world, the imaging that's happening in a dentist's office is many orders of magnitude beyond what's happening in the medical world.
So, quick question for you: what's the scan coverage on a typical dental beam CT like that? I mean, does it go from the skull base to the shoulders, or what's the overall coverage?
Yeah, so I think most of our referring doctors are taking a field of view that basically encompasses the orbits down through kind of the hyoid or the epiglottis. And then some folks are practicing more in sleep medicine and airway, and they can certainly get, like a 20 centimeter field of view, or basically, yeah, the whole, you're getting on most scans, you're getting the orbits, the skull base, the sella, most of the cervical spine, the oropharynx, the nasopharynx, the submandibular glands, the submandibular lymph nodes, and then obviously the maxilla and the mandible and all of the paranasal sinuses. So that would be like a fairly typical field of view for our organization.
Wow. So Barney, you kind of started from the other side, from the dental side. What do you think the overall opinion is from the dentist point of view regarding, who does the interpretation? Should there be overreads? Is there consensus?
I wouldn't say there's a consensus necessarily, but there are so many systems going out the door, as you guys have shown on the previous slide. As a matter of fact, there's a couple of DSOs we work with that are putting out 150 to 200 new cone beams into practices every year, and so wow, the rate of instruments going out is so high that we're starting to reach a significant bottleneck as to the number of scans being taken and the number of radiologists even available to interpret them. So you've seen, a lot of new companies come up, looking at automated image analysis and AI to try to do a better job of doing quick interpretations. From our side, we love it when dental professionals become educated and can do some of the interpretations themselves. That certainly helps if they can look at certain areas and identify certain pathoses or things like that, and then utilize an oral radiologist for that overread or that second opinion. Dental practices that we talk with are really, really busy. A lot of the dental professionals don't have the time or don't want to take the time to do the interpretation, and so it's good that we can be the backstop for them. We've also had dentists who are very educated at looking at exams, have decided they don't want to, or they tend to go look at the specific area of concern. There's a phenomenon called satisfaction of search, where
search,
you go and look at just that one area, and then you might, miss or ignore things going on in other areas of the scan, whether it's pathosis or potential dental treatment areas, including revenue for that practice. And so I think having an overread for those cases is really helpful to make sure that a full comprehensive review of that scan is done by someone who knows what they're really looking at. The other piece of data that's come out in some publications over the last 5 to 10 years is the significant number of incidental findings on these scans. And so that also, I think, gives a strength to the idea of having someone who can look through the whole scan comprehensively and weigh in on those items.
Absolutely. And I think my third bullet, I didn't really write very clearly, but to that point, I was asking if there's an obligation to interpret the images beyond the area of interest, which gets to your point about incidental findings, satisfaction of search, and look at the entire image. And in radiology, I think Dr. Brown can confirm this. CT coronary angiography and CT coronary calcium scoring is a classic example where cardiologists look typically only at the coronary arteries in the heart and forget about these big sacks of air called the lungs and the spine and things like that. So very familiar with that. So to that, what do you three see as being the qualifications for interpreting these studies? Is it just a Wild West where anybody can do it, or is there a consensus or agreement at least as to the minimum experience or the minimum amount of training, or not quite yet, Julie, in terms of interpreting these images?
Well, this is Gary. Just following up on Dr. Brown's point earlier. The cone beam CT imaging field is quickly changing and transforming healthcare. It kind of reminds me of what's happened to telemedicine, particularly in the pandemic. So the whole notion of point of care, that I'm a patient, I'll just use a orthopedics example. I have a knee injury and I can go in and get a weight-bearing cone beam CT image and then have that image read while I'm in the office and have a treatment plan all within, let's say, an hour and a half. That's transformational. And there is a notion that we've inherited from the different specialty societies and the payers and some regulations about scope of practice. So it would not be inappropriate for an orthopedist to interpret my image for purposes of the knee. And the other thing to keep in mind with these kind of we just came back from RSNA and we saw several new cone beam CT systems that are actually full body. So the field of view is going to be a relative term, which can be expansive. So I think pursuant to both Barney's and Dr. Brown's comments, I mean, the overread by a properly credentialed radiologist and many times may be critical, but the starting point, and it's also as part of our standards, you can be a special area with training and baseline experience and ongoing education to be qualified to read a cone beam CT. So that's within generally accepted standards of care. It may not be a best practice, but it's an accepted practice. So I think part of this is trying to find the that balance, right? And just one quick anecdote, not related to cone beam CT system, but a couple of years ago, RadSite was processing and scoring some images that come in as part of a I can't remember actually what the modality was, but we found an undiagnosed tumor. The reviewing radiologist, so obviously that was a sentinel event, but that kind of symbolizes, building what Barney said, that there are particularly things you need to look at outside that field of view. And the question is, if you're a dentist or you're an orthopedist or an ENT or a podiatrist, what's that balancing when you start using a radiologist? So it's definitely changing as we speak, and I'm looking forward to hearing more from my co-panelists about what they think.
Yeah, Barry, Jacob, what are your thoughts?
Yeah, if I would say, just based on the previous slide, and with a number of the sheer volume of scanners that's happening, I'm happy that there's room for lots of different pathways, as Gary alluded to. It makes me happy when somebody, whoever it is, that has some level of imaging expertise is looking at studies, because I'm aware, and we're all aware of what types of things, what types of pathologies can be on an image. And my, I consider myself responsible for every tiny corner of that image, every slice of the 3D volume. And that, that's a perspective that a radiologist takes, but it's not to say that other people couldn't, develop that or take that systematic approach. But it kind of gets back to, one of Barney's points. Like, I'll just tell you a story from one of our referring dentists. She's extremely, forward thinking and conscientious, and is aware of the breadth of pathologies that are within a cone beam field of view. But she has 4 kids, and at the end of the clinical day at 5:30 p.m., she tells us that she likes having an imaging partner there to interpret those images for her, so that she gets home to her kids, without having to stay 30 minutes later in her clinic and try to go through every little corner of every slice of the cone beam CT, and maybe not feel quite as comfortable as she wants to feel for some of those areas. So we love hearing stories like that, where we can be a partner to help people to find things like that.
I can definitely see that.
We have sort of many similar stories to that too, and I think even one of our taglines is bring a radiologist along chair side for your practice. So we kind of want to partner and be that, we use the word backstop for cases where people just need extra help. People frequently ask, how do I get better, as a general dentist or whatever the dental professional is, how do I get better at doing this? And a lot of times it takes sending those scans to a radiologist, and particularly those areas that the person is not familiar with. But once people see a certain thing on a scan 5, 6, 8 times, then they start to know it, and then they can get even deeper into the scan. So we have found some dental professionals' common progression is to send a lot of cases to us initially, and then over the years they slow down simply because they've had the time to look at them more.
Sure, absolutely.
We've also seen the opposite direction, however, where people send us a few and then they realize everything they're missing, and then suddenly every single scan comes to us from then on.
Absolutely. That's all it takes, right?
Yeah.
And so we have a question from one of the attendees. Who do I send a CT to for interpretation? Just got a good one today. So I think we have the right resources here in the meeting. At the end, Julie, perhaps you can answer the question with either or both Jacob's and Barney's information, so that the person can get an answer. And so I think that leads on to a very good point, which is, what are the advantages of using CBCT? Actually, I might change that title slightly now that I've seen it. I would say that what are the advantages and the challenges of cone beam CT? We know that image review and feedback are very important, just as Barney mentioned, and basically providing quality of care and continuous learning. And good CBCT services create high quality diagnostic exams, both in the medical and the dental fields. But then there are the challenges: image quality, interpretation quality. They affect detection of abnormalities, as we talked about. And on the next slide, we can also note that there are a lot of things that go into this that we see, because it does involve radiation. It's radiation dose, dose is affected by age, software updates, inspection, support, QA. So how we know the advantages and the inherent advantages being able to provide imaging at point of care, but is it for everybody? Or do these things that involve creating a high quality image that theoretically and hopefully will be reviewed and validated through an accreditation organization, how do you make sure the image quality is where it should be? Are there set standards out there right now at all regarding equipment age or physicist visits or anything like that? I'll ask Barney.
Oh, sorry. Go ahead, Patrick.
I was going to say, well, how about we have Barney lead with that one because it's more the user interface. And then Jacob, I think you can definitely talk about possibly the variation quality of the studies you see.
Sure. So some of this falls to the idea of, the ALARA principles, or as low as reasonably achievable in terms of radiation dose and exposure and things like that. And so a lot of most dental offices will start with a set of bite wing x-rays. And then if they need a little bit more imaging, they'll move on to using a panoramic instrument, both 2D sort of views. And those have had a long history of being able to, get dental insurance reimbursement for those. And those are the first common paths. If someone has a cone beam in their practice and they see things on that imaging that they're not comfortable with or don't like, then that's sort of where dental cone beam CT comes into play and is used as a tool. And so it then gives that additional, third dimension and being able to scan through each of the axes and look at slices. So it just gives a lot more visibility to things that might be hiding that you wouldn't see on a 2D image. Some practices follow that path. Others go straight to dental CBCT and just take the scan.
I can imagine.
And so we see a variety there. With CBCT, I would say it's like any new tool. It's fancy, it has a lot of options, and becoming a responsible user is the key. And some people will get education from the vendor, they'll seek third-party education. One of the things that we enjoy is an opportunity to help just simply educate, whether somebody's sending a scan for a radiology report or not. And part of that education can come through the path of someone sending us scans over and over, but they're of very low quality, barely diagnostic quality. And then empirically, they can work to adjust settings on the instrument, either with us or in many cases with their instrument manufacturer involved, to dial in the right image quality.
So Jacob, have you seen that sort of variation in image quality? And if you do, how do you approach the poor quality images through either feedback or I guess just refusal to read the studies? What have you seen?
Yeah, we've had all of those instances, right? So one of the advantages of a helical CT scanner is that it actually scans faster than a cone beam CT takes, on the order of 10 or so seconds. So it's a little more, as that's moving horizontally over the patient, it's a little more susceptible to some motion. So the patient has to hold still. And that's definitely one of the things that we've seen a lot of is motion. And then radiation dose. We want, if you are going to irradiate a patient, even though this is a relatively tiny amount of ionizing radiation, we want to make sure that we're obtaining a diagnostic quality image. So our radiologists do put qualitative assessments of image quality in the report, so that feedback is getting to the referring doctors. And also there have been instances where our radiologists say, hey, this isn't sufficient to make any, this is not a diagnostic quality study. And that in itself is its own, useful feedback. But I think it just highlights what the reason why accreditation bodies like RadSite will be so important with any emerging technology like this, especially in the dental field, which in some ways is subject to fewer regulatory standards than the medical world, or at least it's not as uniform, I should say. And so I think there's greater opportunity to bring everybody up to a little higher standard of quality. But certainly from the user interface standpoint, I think when I'm thinking of like my brother or the people that I know that are practicing dentistry, I think just the volume of studies and then kind of the downward pressure from manufacturers to kind of have these basically you make a significant investment in these scanners, and then you're kind of left the person, the ordering doctor is left to decide, which of these patients am I going to scan. I kind of have in the back of my mind that I need to recoup some ROI on on the scanner that I purchased. So all of those challenges, and then the increasing volume of imaging studies and images that you have in your office, and how do I store those images? Am I going to take the approach where I look and I try to see if there's anything that catches my eye, and then I'll send that to somebody, to my friend or somebody I know to review? And our organization has tried to eliminate some of that friction by, our software team has focused pretty extensively on having a sync feature for the acquisition computer that operates the scanner. And that model follows what we do in the medical world, which is every DICOM image or series of CT images that's obtained is automatically sent through a pipeline. So that friction point of, I have this giant, I have all these files on my Windows computer somewhere back there in that office. And do I really want to go back there right now and start?
Yeah.
So do I need to sort through which ones I need to send? And we just want to remove all possible friction to somebody having an imaging expert review the study.
Yeah, definitely. And then also, one of the things I've been somewhat surprised about is the variation in QA and testing and phantoms and vendor recommendation regarding maintenance and everything else. Have you guys seen an equally wide variation in all those subjects? Yeah.
Yeah, this is Gary. I'll say, clearly, again, because it's emerging imaging application, for example, we've not seen a whole lot of commercial-based phantoms. Most of the national physicists that do the cone beam CT physics testing for these systems kind of are backing into it through some combination of the manufacturer phantoms. And in this case, RadSite recognizes the manufacturer phantoms for physics testing. And as alluded before, there's really not a whole lot of comprehensive regulation on this. So I do think that, the short term, the RadSite standards, which mimics, again, the rigor of the traditional ADI standards, will be a pretty important proxy of the physics testing and the QA that, for example, payers and others will accept. But I did want to follow up on kind of the general theme of these slides here. Again, another medical example. I was talking to a chiropractor earlier this year, and for their practice in terms of how they did manipulations, and I'm a layperson, so I don't know if this is or not, but he would shoot 3 to 4 X-rays, take measurements, do the manipulation, and then shoot 1, 2, 3 X-rays on the back end to see the effect. And what he was saying is basically with the cone beam CT system, he was able to take one image at the beginning, one image at the end, which in this case not only gave him the clinical insights on the measurements with the one image, because he could take the measurements because it's 3D, but also in this case it meant less ionizing radiation for their patients. So to me as a layperson, it's really exciting to see the clinical applications and the basic acquisition protocols being developed for these different areas. And sometimes the machine gets ahead of the protocols. Sometimes the protocols are there and then they make machines around the protocols. The challenge is that the FDA and the kind of approval of these machines really don't take into, don't consider enough the actual interpretation of the images. And in this case, the ongoing, there are many of these machines that have been in the marketplace now been installed for over 10 years that probably not gone through any third-party physics testing or any meaningful physics testing after the initial installation. So I do think it's kind of a multi-tiered challenge with a multi-tiered opportunity. But I'm personally very excited when I see each of these different specialty areas in terms of the clinical pathways. And it's also, I think, important to understand what a cone beam CT is good at in comparison to an X-ray, and also when and if a traditional CT may be more appropriate based on its ability to detect certain types of potential disease states more than an X-ray or cone beam CT, for example.
Definitely, completely agree.
Gary,
So
I
that
think
actually,
that's something
oh,
you
go ahead,
said,
Jacob, sorry.
and Dr. Brown as well, about the friction points that these practices have just to get help and to get the level of expertise that they need. And one of the things that I get particularly excited about when people ask me about accreditation is that I know that that practice is about to go through a process to up their education or refresh their education about what they're supposed to be doing. You know, because for many practices that we run into, not only is it the nuances of the particular cone beam CT that they're getting, but it's also their first cone beam CT. So when it arrives in the door and is installed, you know, usually that one-day training, they're drinking from the fire hose effectively to get this information. And we do our best to provide, you know, education resources and, you know, short videos about how, you know, things that affect image quality and things like that. But just the process of going through accreditation, regardless of the impetus for the dental practice or the group to go through it, just to go through the minimal requirements of sending 3 images in for accreditation and possibly another set for the specialty they're going for, or you know, going through the checklist for accreditation probably refreshes a lot of people's minds of, oh yeah, I'm supposed to be calibrating at this particular frequency on my instrument. I should look into that. Or, oh yeah, I should, you know, do whatever the item is. So I think those things also help people visit or revisit each of the items you have here. How old is my instrument? Is it still giving me quality images? Have I done any software updates, or is this unit completely shut off from any sort of software updates? Getting support from the vendor, whether it's service inspections or looking at various QA measures. I think this really helps people, push people along.
And Barney, you were going to say something, I thought, or?
Oh, sorry. Yeah, I think that was Barney. Thanks, Barney. But yeah, I would just say, like, I think the attendees that are attending this webinar we have some self-selection, right? The people that are listening to this webinar already want and to do the best thing for their patients and for image quality, and they're aware that there should be some kind of QA happening, and they're probably starting down that road of, how do I start getting to think about. I'm a little more worried about maybe I don't know how many attendees we have here, but the potentially thousands of other people who, you know, don't have RadSite or another accreditation body on their radar, or don't have any, you know, I'm wondering, how do we get, given the sheer number of scanners that are out there and the utilization, how do we bring more people into this kind of education and awareness fold here, I guess?
That, you know, Jacob, I'm going to give you an extra $20 because that leads perfectly to our next slide. So, because one of the things that I think I always try to keep in mind is not necessarily what's the value of accreditation. We talked about that already, I think, and touched on all of the value props associated with it. But my question is always, how do you create and illustrate the value of accreditation to people who might not have a currently accredited machine, or might have an older machine, or the overall process just has never actually gone through accreditation? RadSite has been doing some work with other organizations within RSNA about how to create standardization in other imaging modalities. And one of the challenges we've had in engaging imaging practices into the process of accreditation is, just as you said, there's a wide variety and variation of image quality, equipment age. I think there's some degree of underlying concern that they might not pass, and then what does that mean? And at the end of the day, then they also say, well, what does it really matter? I get paid no matter what, and image quality really at the end of the day doesn't matter that much. I'm a firm believer, as I think we all are, in great patient care, so there's always that, but it's always a challenge. Is how do you create the impression that going through accreditation, having a high quality machine, providing good images to either the dentist or the radiologist, or both, how do you create knowledge that that is a good thing to do and should be done when it hasn't been done before?
Just real quickly in response, Dr. Brown and Dr. Barney, to your last comments. I mean, clearly part of what we're trying to do here is initiate a public policy dialogue beyond this webinar. as one interim step, we'll, in addition to hosting this webinar on our YouTube channel, so hopefully other people will find it. I know we'll write up at least one blog, if not more, on some of the key points made today. But most importantly, initiating a dialogue with the various stakeholders, starting with the patients, including the payers, to really elevate kind of the thinking about this, because it was one, cone beam CT still arguably is still one of the best kept secrets from some stakeholders' perspectives. And for example, we had a webinar last month on really how you measure dose for cone beam CT in a way that's meaningful based on the cone beam acquisition technology. So, what we'll try to do is kind of promote the dialogue and buckets and really get people to embrace. I mean, clearly, if it is about the patient and their diagnosis and treatment, then clearly cone beam CT has a significant role in these different specialties we've been talking about. But then again, in terms of the theme today, in terms of the interpretation, there are things that we need to be doing. Both ACR and RadSite, for example, have some peer review requirements that even if you're a radiologist working by yourself, you need to have another radiologist, randomly, peer review some of your interpretations. And, as a side note, there's a huge, and I think I don't want to jump ahead in terms of perhaps another slide, but the whole issue of artificial intelligence. So there's still the issue of interpretation, no matter who's doing interpretation and how actionable that information is and how accurate based on the diagnosis, again, the treatment plan. And so this is really something that permeates all aspects of imaging and radiology. So I think part of RadSite's mission, with your help, because you're all volunteers here today, is to really help us elevate the discussion and bring people up to speed. I know I'm personally excited the more I learn about again, I used the example of a knee injury. I mean, I think it's important if I'm getting a knee replacement that perhaps that they see exactly what my knee's doing when I have weight on it. So I think that there are many, many examples of where there's clinical indicators for a cone beam CT image. The problem is that it's not been actively supervised. So I think it's a combination of professional responsibilities, the accreditation agency's roles, regulators, all trying to catch up to this technology. And again, analogous to kind of how telehealth, telemedicine has swept the country in recent years, I think people are going to like the convenience of going to your treating provider and actually having the image there done instead of having 3 appointments. So I'm really excited, but we all, again, to Dr. Brown's point, we have a lot of work to do to kind of get the word out, and I guess in some respects stir the pot in a positive way, but make sure that we have suggestions and remedies on how to resolve any particular issue related to optimizing the taking of a CBCT image and the interpretation of it, and then how that information flows back to the patient and the treating provider.
And Barney made a point before we started the seminar. Barney made a point too that there's an interesting mix depending on your location as to whether or not the patients are cash pay, whether they're cash pay and hoping for reimbursement from third-party payers, whether they're third-party payers paying for it. How do you guys think that conversation or that concept affects accreditation? Does it really require an insurer or payer saying, no, we're not going to pay for this unless you're accredited? Or does patient perception of quality drive accreditation as well? Or what are your guys' thoughts?
Well, just to cue that up real quickly, in terms of MIPA, if a cone beam CT is being billed pursuant to a medical CT code, most payers are going to mandate accreditation from one of the 4 recognized accreditation bodies as part of everything else. What becomes a little more ambiguous is the conversion from dental insurance, mouth versus body, combined to medical insurance, and the differences between deductibles and out-of-pocket costs, et cetera. So there's certainly been a tradition in many instances, particularly in the dental field, to bill the patient directly, but that should not necessarily be the right thing to do. So part of this is RadSite, for example, is working with a number of different interested parties to help, develop the payer guidelines. We just heard recently of actually the first cone beam CT modifier for specialty cone beam CT, practice area. So I think it's all coming, but right now, to your point, Dr. Barney, it's kind of a wild west of reimbursement.
I mean,
Oh, sorry, Barney, go ahead.
Well, I was going to say, I'm coming into this idea of accreditation and what it means literally probably in the last 16 months or so, and trying to learn as quickly as I can. What I'm kind of learning as for myself is that, you know, when you go seek a service from anybody, whether it's getting your car repaired or your bicycle repaired, you want some sort of information that the person knows what they're doing. And while it's evolving, I definitely feel that we're going to a path where if anybody wants to submit data or information that's come off of any imaging equipment, the payers are going to say, okay, well, show us that you know what you're doing, that you actually know how to do this. Yep. And accreditation is certainly standing out as that path right now, because it requires the person to go through everything with that instrument to show that they're a responsible user and they know what they're doing.
Good point. And Jacob, your thought?
Yeah, well, I would just say that, I mean, there's a lot to be worked out, of course, and I applaud RadSite for these incredible efforts. I do feel very optimistic about us being able to promote best practices and elevate the standard of care at the point of care, based on just kind of going back to the principle that I think I mentioned this to you recently, that, you know, when we went to dental school or medical school interviews and people ask us, why do you want to be a doctor? You know, we said with sincerity that we want to help people. And now Patrick's smiling because we have some sediment that starts to build up, some layers of sediment that kind of tends to accumulate over the years. But we believe that, and people want to do that. And I was recently in front of a couple hundred dentists, and when you show them quality images that came from their offices, and I show them the types of pathology, the breadth of pathology. We're preparing some data for publication right now, and I asked, from the last 1,300 scans that our radiologists interpreted, I asked them to mark whether or not they found unexpected findings that could potentially result in an adverse patient outcome if it wasn't followed up or referred for additional imaging, such as MRI. And the rate was 1 in 13 of these cone beam CT scanners. So that isn't like an incidental finding, like a mild, like nasal septal deviation. That's like a finding that could potentially cause an adverse patient outcome. And I think education.
To interrupt, you're saying that of the number of cases you had, there were 100 patients that had significant findings. Wow, that's impactful.
So one out of 13 of all of the patients that were scanned. And when you present that to the audience, and these are scans that come from their offices, and you say, you know, having a high quality scan, making sure that your scanner software is up to date, ensuring appropriate radiation dose, all leads to a higher quality image. And then having an imaging expert partner there to make these diagnoses for you helps you take care of patients in a better way and keep your patients safe, and potentially eliminate like a big crazy loop where they come to me in the hospital. You know, if you can potentially cut that out, where they spend months kind of, you know, one of our radiologists recently diagnosed an inner ear problem from a cone beam CT. And, you know, when we think of a cone beam CT in a dental office, sometimes people will say, that's a dental scan. And I would say, just because it happened in a dental office doesn't mean that it's a dental only scan. Obviously, the dentition is a super important part that we're focused on, but this is a head and neck scan. And so our radiologists have identified inner ear pathologies that can sometimes result in months of being bounced around to ENTs and neurologists and MRIs before they finally get a CT scan at a much higher cost and a higher radiation dose at an imaging center or a hospital-based imaging center. And when you show that to referring dentists and referring providers, and you say that accreditation is part of developing higher quality imaging and providing better care for your patients, if the education component is so critical, and I've found that people just are naturally buoyed up by that and come along with that.
Good. That's good to hear, because that's my feeling as well. I hopefully don't have as much sediment built up as it may seem sometimes, but
I wasn't sorry. Did I single you out, Patrick?
oh,
Sorry.
no.
You look like you're
totally
enjoying
good.
your practice of medicine. Good.
It's just the hair. It's just the hair. But no, one of the reasons I value RadSite so much is it does a good job of recentering me and other radiologists and other imaging center owners into the fact that at the end of the day, it really is about the patient, and it's about making sure the patient's getting a good quality scan, being treated well, and hopefully all the visible pathology is taken care of. I think that's the most important thing. So let's move on to our last slide. Along the lines of what you sort of talked about already, Jacob, is workflow. One of my personal observations is that CBCT is very much like the very early days. I mean, I wasn't alive during that time, but the very early days of CT and MRI. I mean, back when people were still looking at films and hanging things on alternators, and then PACS came in, and it really revolutionized the way we do our work and where we do our work and everything else. It strikes me that CBCT is sort of in that very beginning infancy phase where you're trying to sort things out. Dentists are trying to figure out how to make things as workflow friendly, make sure they don't miss cases, make sure they don't lose images, a lot of different things. Are you all seeing the same thing? Is it just in this early stage of development where RadSite and expert organizations such as BeamReaders and DentalRay are able to help guide quality and patient care in a way that's really beneficial, both for the patient and the clinician? Long sentence, sorry about that.
Yeah. I mean, I would say this is tremendously challenging. As a dentist, you're often like a solo entrepreneur. You're a small business owner. You're managing you're the HR in your business as well, and you just have so much on your plate. And the scanner, I'll go back to my brother's office, the scanner's down the hall, and it's this one computer that's kind of this orphan Windows system. I don't and it's not really talking to any of the rest of his practice management software. So there's so many hoops that people are currently jumping through to try to get to the point. Even if you want to review and do a good job of reviewing, is standing in the hall with people, with staff, walking by you, trying to get back to the next patient. Is that the way that we want to be, interpreting radiology studies? And Patrick, that we sit down in a darkened room and we try to have a distraction-free environment, and we have big monitors in front of us, and we try to provide best practice. And we're so focused. Our organization is so focused on eliminating all of those friction points for the providers, because we know they have way too much on their plate already.
Yeah, that's great. And actually, one of the things that Barney gave me sort of recurring PTSD about is the use of CDs to send studies back and forth between different radiology practices. It drives me crazy. And I can just see the originator of your company just being surrounded by all these CDs that he's shoving into the computer and looking at on a computer and everything else. And I think that if we can help guide people into realizing that isn't the be all and end all way to be able to do the imaging, there are higher quality ways to do it and treat their patients better. It seems like you would be very enthusiastic about something like that. Would you say, Barney?
It's certainly fun when we hear from certain imaging centers or other groups who are still today using CDs to send images and information back and forth, and we share them, modern tools like, sharing cases and sharing case information through a secure portal like we have, and just the light bulbs go off and they think, really, we don't have to try to find computers anymore with CD drives. So that's nice.
Absolutely.
The one thing I wanted to add here on this last slide is talking about improving clinical workflows. One area we've seen evolve very rapidly just lately is particularly in endodontia. And the idea that now you can actually see these canals and the twists and turns that they make. And it's driven pretty significantly the evolution of tools used in endodontia to be able to do root canals. And
Oh,
so it's been fun to see some of those developments.
interesting. That's a great point. I hadn't even thought about that.
Yeah.
And so along those lines, we're getting towards the end of the hour. I wanted to leave time for questions if there are any, but I wanted to ask all three of you if you could just maybe give a summary about where you think things are going or what are going to be the most important factors in the next couple of years in CBCT, both for dental and medical. And start with Jacob.
Yeah, I mean, well, clearly I come with a bias that medical imaging is just awesome, and I love it.
Oh, absolutely.
So and really we're getting to, you know, a lot of times the heart of what brought the patient there, and we're, you know, helping diagnose things earlier, cutting out potentially these pathways that result in frustration and multiple visits for patients. And I'm just so impressed at the work that's being done to bring this imaging to. I've always loved imaging technology and being a radiologist and answering the question for my clinician colleagues. But now that this imaging technology is happening at the point of care where the patient is, without any separate visit and with a lower cost and lower radiation dose, I'm extremely excited and optimistic about the future. And I'm excited to be on this panel with all the other organizations that are here, because there's need and room for all of us as this technology continues to improve. So I love it.
That's great. And how about yourself, Barney?
Yeah, certainly the question that always comes to my mind and keeps me up at night is how do we take care of patients even better and faster at the point of care? You know, and there's certainly evolution to happen, but you can imagine a situation one day where a patient comes in and is scanned, and AI assisted radiologist is, you know, cranking through what needs to be reviewed in that scan and getting that information back to the dental professional or medical professional almost immediately or as quickly as possible. And it feels very much like we're going that way. Tools are starting to be developed that push in that direction. So it's an exciting time that's coming along. Excellent.
And how about yourself, Gary?
Yeah, I've been choking on my seltzer water, so I'm all choked up. So I apologize. But, you know, real quickly, I think just to reinforce the notion that this is a community-based effort. I recall an experience I had probably about 6-7 years ago. I was working with the American Telemedicine Association on their telemedicine integration program. And really the first thing we had to do is create a typology of what virtual care is. And I do think that there's so many themes interwoven with Cone BCT about, you know, technology, point of care, better clinical information, but it all is dependent upon the proper interpretation of images, making sure the machines are calibrated, even though they're simpler in theory than a CT. And so it really is going to take a community to move this forward. And I think we've started that. And, you know, all stakeholders that have an interest should participate. So I think we're off to a great adventure, and perhaps we've hit that tipping point where things are really going to start moving forward. I mean, clearly the dissemination, the equipment themselves already happened. Now we have a chance to follow up with the clinical protocols, make sure at the end of the day that the highest clinical fidelity is being realized through this. And, you know, to Barney's point as well, making sure, again, at the end of the day, you have actionable information for the patient and the treating provider at the point of care. So I think that it's similar to telehealth. Telemedicine is really kind of where we're heading. Not that hospital-based imaging or outpatient imaging is going to go away, because clearly those are clinical settings that have a very important purpose as well. But just this as an add-on, definitely will, from a population health perspective, could be a very helpful thing.
Absolutely. Well, we've reached the end of our time. I don't see any questions. I wanted to thank all of you for being such excellent participants and panelists. And also additionally, thank Gary for showing up at the last second to be able to fill in for Judith, who was not able to be here. Thank you all very much for your time. And if there are any questions on the part of the audience, please feel free to contact Julie and she'll be able to pass it on to any of us. And with that, I will pass it back over to Julie. Who's muted? There you go.
Thank you. RadSite would like to thank you, Dr. Browning, as our moderator, and our panelists, Dr. Jacob Brown, Barney Miller, and Gary Carneal. We do miss Judith Turner and her perspective. She was on your last webinar, I believe, correct?
She was.
So yeah, that was about traditional CT imaging. If you do have additional questions, feel free to contact us at info@radsitequality.com. You can find that also a contact us form on our website if you need that. And just a reminder, today's webinar has been recorded and will be available through our website. And if you enjoyed today's presentation, be sure to check out the webinar page on our website for past recordings. We hope you will continue to join us for upcoming webinars. Thank you.
And thank you, Julie.